डॉक्टर ज्योति ज्वाइन कर लो.
Good evening, ma'am.
Hello, Mr. Vinod, you're giving the countdown or we are still waiting for some time?
Yeah, countdown already over, ma'am.
On है, मुझे दिख नहीं रहा क्यों?
ये ओवर हो गया मैम, वो चल रहा था 2 मिनट का.
अच्छा,
दोबारा चलाऊं क्या?
तो नहीं, तो हम स्टार्ट करें. आर वी लाइव?
स्टार्ट कीजिए मैम.
Good evening, everyone. It's my pleasure and privilege to initiate this webinar on adnexal masses organized by Institute of Obs and Gynae, Sir Ganga Hospital, New Delhi, under the aegis of ISOPARB Delhi chapter. Adnexal masses always dodge us because all our patients wants only minimally invasive surgery, but we have to decide as a clinician which patient requires minimally invasive approach to adnexal mass and which patient requires laparotomy and frozen and then proper treatment of this particular adnexal mass. Today evening, we have galaxy of star speakers who will guide us and tell us which adnexal mass has to be treated as a benign and which adnexal mass can be a suspicion of being malignant. It's my pleasure and privilege to invite chief guest for the evening, Dr. Gujral Madam. Madam is chairperson, Institute of Obs and Gynae, Sir Ganga Hospital. Madam is in charge of high-risk pregnancy clinic. She has been past president NARCHI Delhi, past vice president AOGD NARCHI, past vice president of NARCHI All India, past joint secretary Indian Menopause Society Delhi chapter, national vice president, past editor Journal of Fetal Medicine, past president of DGF Center, advisor of DGF Center, President Society of Fetal Medicine Delhi chapter. Madam has been a member of the editorial board of quite a few journals, published many papers, chapters, delivered guest lectures in national and international conferences. And Madam has received multiple awards for her excellence in high-risk pregnancy. Best part is this, Madam has always encouraged us in all the academic activity that we do from the department, and she has always encouraged us in all the endeavors that we do for the department. Madam, we are waiting to hear pearls of wisdom from your side. Over to you, Madam. Ma'am, you are muted.
Ma'am, unmute, please.
Ma'am, please unmute yourself, Madam. Dr. Gujral, Madam, we are waiting to hear from you, Madam.
Hello, can you hear me now?
Yes, Madam, we can hear you.
Can you hear me, please?
Yes, Madam, we can hear you.
All right, your voice is so light. Anyway, thank you, Mala. If I'm heard there, I'll just speak up my part. Thank you for letting me be the so-called chief guest, and thank you for the lovely introduction. All I have to say that Institute of Obstetrics, Gynae, Sir Ganga Hospital and ISOPARB, under the aegis of ISOPARB, it's a very, very vibrant society. Time and again, we are holding, webinars which are very useful. And this one in particular, a webinar on adnexal masses. As you're all aware, 8 to 35% of the premenopausal women and 3 to 17% of the postmenopausal women will present with an adnexal mass. With the help of a good history, physical examination, ultrasonography, imaging sciences, and tumor markers, a clinician should be able to diagnose the benign ones, decide which ones need to be operated, which ones can be going on a conservative management, let's say, and something like endometriosis, and also be able to appreciate the benign masses, all the benign, but they have potential for malignancy, which may be low. What is the surveillance required for these women? And definitely be very apt in diagnosing malignant ones. because that is what is important. And most importantly, the clinician, the gynecologist should be able to decide which mass should come in the domain of gynecologist, which mass should go in the domain of gynae oncosurgeon, because whatever the data is there, the better results are there once a gynae onco deals with the malignancy, howsoever good a general gynecologist may be. Now, this webinar will deal with these issues. The lectures have been very carefully chosen. The first lecture by Dr. Jyoti Meena tells us how to go about an approach to an adnexal mass, how to approach it, what to do with it. And Deeksha, Dr. Deeksha, imaging sciences person, will tell us IOTA, which has been tested, tried, proven, and very, very informative. And lastly, you will have review of the literature regarding masses and what are the society guidelines which we should follow. With those few words, I hand it over to the chair to start the scientific proceedings. Thank you very much.
Thanks, madam, for your pearls of wisdom. It is always nice to get a review from you and encouragement for you. You always gives us lots of boost in all our academic activity, whichever we do.
Thank you.
Now we start a scientific program. And to conduct the scientific program, I will invite a young, enthusiastic, energetic, intelligent Dr. Anuva Mohal, who is the Senior Resident, Institute of Obs and Gynae, Sir Gangaram Hospital, and she'll be holding the thread throughout this evening. Over to you, Dr. Anuva, to conduct the scientific program of the evening.
Thank you so much, ma'am, for the lovely introduction. Moving to the next part of the program, I'll invite Dr. Meena Sawant, ma'am. Meena Sawant, ma'am, is a known name, as we all know. She's a senior consultant. She's a senior consultant and HOD OBGY, Kurji Holy Family Hospital, chairperson of Foxy Research Committee, Secretary General, ISOPARB Executive Committee, member Patna Obs and Gynae Society, organizing secretary Boxcon 2018 Yuba Foxy 2011. She has been awarded Kamini Rao Ration 2005 award. She has got various publications in reputed journals and many chapters and books. Especially interested in high-risk pregnancy, ma'am, I'll request you to introduce our speaker, Dr. Jyoti Meena, ma'am, and give us some introduction about our topic, evaluation of adnexal masses.
Yeah, I would not like to take that privilege of Dr. Meena from that, because we're going to hear her. She's the expert in this field. But it is my pleasure to introduce Dr. Jyoti, who is the additional professor in the Department of Obs and Gynae in AIIMS, our premier institute in Delhi. And her area of interest are gynae oncology. So what better than her to talk on this subject? And she has over 50 papers and 4 chapters in books to her credit. And she has been, awarded by various prizes. One of them is Dr. R.P. Sonawala Award for Best Oral Presentation in AICCRCOJ 2019. Foxy Dr. Karan Gupta Memorial Prize for Best Poster in ICOT 2020. And she's, affiliated to so many member bodies, societies, the Foxy, NACHI, ISCCP, EGOICAN, ESGO, member of Educational Committee, ESGO. So, ma'am, we all are eagerly waiting to listen to you.
We have to introduce another chairperson for the evening, Dr. Harsha Pullar, madam. Madam is a senior consultant and at Institute of Obs and Gynae, Sarga. Been associated with so many positions in different societies. Madam had been secretary of AOGD, ex-joint secretary, IMS Delhi chapter.
Part. Let's go ahead with the scientific part.
Okay, ma'am. We'll have the privilege to listen from you once the lecture is on. Over to you, Dr. Jyoti, for your scientific deliberation.
Thank you, ma'am. Thank you for the kind introduction and giving me this opportunity. I will share my slide. Is my slide visible, ma'am?
Yes, ma'am, it's visible.
It is visible.
I will do. So today I will be discussing about evaluation of adnexal masses. So as we all know, first important thing is what is adnexa? So the adnexa we defined is it is an area that is adjacent to uterus and it contains the ovary, the fallopian tube, ligaments, and the vessels. So it is collectively known as adnexa. So the prevalence of the symptomatic adnexal masses, it accounts for around 1 per 1,000 in premenopausal women, and after the age of 50, it is 3 1,000. So the postmenopausal adnexal mass incidence is around 5 to 17%. However, the overall of these adnexal masses, a most common one are the benign pathologies, which account for 65.7% as compared to the malignant ones. So among the benign pathology, most common are the endometriomas in the reproductive and younger age group. And among the malignant pathologies, the invasive cancers are more common. And even the borderline also persists, which is around 5.1%. So this was a population-based cohort study which was done in Netherlands, which included the adnexal masses in children, adolescent, and women of reproductive age group. So they took 11,595 patients, and they found that the incidence of adnexal masses, it increases exponentially with age. It was around 0.43 per 1 lakh women years at the age of 1 to 15, and at 35, it was 2 per 1 lakh. In the premenarchal age groups, most common tumors that were found were the germ cell tumors. And in around 1 to 8 years group, the sex cord stromal tumors were more common. And in reproductive age group, the endometriotic cysts were the most common adnexal masses that were found. So if we look at the etiology of these adnexal masses, they can be gynecological or non-gynecological masses. Among the gynecological masses, they can be ovarian or extra-ovarian. In the ovarian and extra ovarian, we can have benign and malignant masses. So the most common, the benign ovarian masses includes functional cysts, cystadenomas, endometriomas, dermoid, polycystic ovaries. And among the malignant ones are the epithelial tumors, germ cell or the sex cord tumors, and even the borderline tumors. Among the extra ovarian, the benign ones includes, as we all know, there can be a large hydrosalpinx, which can present as a abdominopelvic mass, or there can be tubo-ovarian abscess, ectopic pregnancy, para-ovarian or the peritoneal inclusion cysts, and even fibroids, especially the pedunculated or subserosal fibroids or the broad ligament fibroids. They can present as an adnexal mass. Among the malignant one in extra-ovarian includes the fallopian tube carcinomas. In non-gynecological, there can be appendicular masses, or there can be pelvic kidney, peritoneal cysts, or there can be Klukenberg tumors, or even retroperitoneal masses can be there. So there can be different etiologies for an adnexal mass. So why it is important to evaluate adnexal mass? Because we want to do an appropriate workup, and the pre-operative assessment is to know whether there is any malignancy. However, in the diagnostic workup, it is very challenging. Why? Because there is a diversity in the clinical presentation. There's a plethora of differential diagnoses we have, and there's a wide range of therapeutic options. So it is very important to identify the high-risk adnexal masses. Why? Because now we want to know whether we want to go for a conservative approach or we want an immediate surgical intervention. Then what should be the route of the surgery? Whether we can do a laparoscopy or we have to go for an open approach. Whether it is to be referred to a gynaecologist or can be done by a gynecologist. If we are opening it, whether we need to open it by midline vertical incision, because if it is a malignancy, then you need to explore a whole abdomen. You have to take multiple biopsies, or you can go for a transverse incision. And whether a frozen section is required or not to make the decision on table. Or you can do a conservative surgery or complete surgical incision. So evaluation of these masses is very important. So the main goal of this evaluation, one we have discussed that it is to determine whether the mass is benign or malignant, and another is to do an appropriate workup so that further treatment plan can be made. So in evaluation, all that is required is a good history taking and examination, imaging, and tumor markers and routine investigations. So first we will look for history. So in history taking, very important point is age, because age is an important risk factor. Duration and of the presenting symptoms, menstrual history, whether the patient, if a patient is of endometriosis, she may present with dysmenorrhea, or even dyspareunia if it is a deep infiltrating endometriosis. What is her reproductive status, whether she's nulliparous, multiparous, then whether she has taken treatment for infertility, her sexual history, her menopausal history, any history of intake of OCPs or HRT, and what is her family history. So these are very important. Because age, why age is important? Because according to the age, we can have a differential diagnosis pertaining to that age group. Suppose a premenarchal girl come with adnexal mass, then what differentials we will think is, either we will think of a germ cell tumor, mature teratomas, or even rhabdomyosarcomas. If she is a young girl between 15 to 25, then more common are the functional cysts, germ cell tumors, or teomases, dermoid, PID, ectopic, or endodermal sinus tumor. In 25 to 35 years, again, endometriosis or serous or mucinous cystadenomas can be there. In advanced reproductive age group, we can think about endometrial stromal cell tumors, granulosa cell tumors, or endometrioid cell carcinoma. In perimenopausal and postmenopausal, one has to rule out ovarian malignancy. So in symptoms, either the patient can present with presenting complaint, or they can be the masses can be discovered incidentally on pelvic examination or imaging. The most common symptom is the pelvic pain. Whenever the patient presents with pain, it is very important to note what is the onset of the pain, what is the location of the pain, duration, whether the pain is constant or intermittent or associated with other factors, whether there is associated abnormal uterine bleeding, or there is associated any dysmenorrhea or dyspareunia or vaginal discharge. Sometimes the patient may present with persistent serosanguinous vaginal discharge without a fever, not relieved on any treatment. One should keep an high index of suspicion regarding fallopian tube cancer also. So in the symptoms, we have a GOF symptom index, which includes pelvic pain, abdominal pain, increase in abdominal size, bloating, difficulty in eating, and fullness. If any patient has any of these symptoms with onset less than 1 year and more than 12 times a month, then one should think about an ovarian pathology, and that through malignancy. But if there is a predominant GI symptoms like vomiting, altered bowel habits, constipation, then GI malignancy should also be ruled out. The sensitivity of this index is around 56.7% for early stage, and for late disease, it is 79.5% sensitive. The specificity is about 90% for women aged more than 50 years. So one should keep in mind what are the symptoms of these of this adnexal mass. Now, if we look at the family history, it is very important if a patient presents with adnexal mass or patient is a diagnosed case of ovarian cancer, then also it is very important to take a family history, whether there is any history of ovarian cancer in the family member. If there is one affected family member with carcinoma breast or ovary, then the risk of adnexal malignancy is around 5%. But if it is associated with any mutation, if there is presence of any mutation, especially the BRCA1 mutation, then the risk increases to 41 to 46%. In BRCA2, it is 10 to 27%. And if there is associated Lynch syndrome in the family, then it is around 8 to 20%. Or even in the patient, if she has a diagnosed Lynch syndrome, then the risk of malignancy, adnexal malignancy, is around 8 to 20%. Additional risk factors also should be taken in note of. That is, patient is obese, nulliparous, whether there is history of early menarche or late menopause, or patient is infertile, taken treatment for infertility, or has a long-standing endometriosis. However, the protective factors are also there, which includes tubal ligation, and even use of OCPs are considered to be protective factors. So now further in evaluation, besides history, includes the examination. So in examination, one should do a thorough examination and also look for the performance status of the patient, that is according to the ECOG scale. Then a head-to-toe examination should be done, which should include not only from hair to toe, but also the breast examination, thyroid examination, and supraclavicular or axillary lymph nodes. BMI should also be noted. Then coming to the examination, in per abdomen examination, one should inspect how is the abdomen, whether it is distended, whether there is uniform distension or there is a localized distension. What about the skin over the abdomen, whether it is stretched or shiny, especially in cases of ascites, whether there is dilated veins or there is edema of the abdominal wall. And then in palpation, one should look for the temperature of the overlying skin. One should look for the abdominopelvic mass. So if the abdominopelvic mass is present, in which quadrant it is present, upper abdomen, lower abdomen, on the right flank or the left flank, what is the size of the abdominopelvic mass? What is the consistency of the abdominopelvic mass? How about the surface, whether it is an irregular surface, it is a smooth surface, whether it is cystic, solid or solid cystic mass, borders, whether the lower limits can be reached or not. Important thing is the mobility of mass also, whether the mass is mobile, freely mobile, restricted mobility, or there is presence of any deposits on the abdominal wall, or there is any tenderness. Besides this, inguinal lymph nodes should also be palpated, because sometimes this can give you an idea of the metastasis also. Then if we talk about the local examination, besides the local examination, we look for any lesion in the vulva and vulva. Important thing is do a per speculum and per rectal examination. The per vaginal examination will tell you about the size of the uterus and also the adnexal mass. Then what is the relation of this adnexal mass with the uterus, whether it moves with the movement of the adnexal mass, what is the consistency of the mass, whether there is any tenderness on bimanual examination or not. This all we can make out from the per vaginal examination after per abdominal. Besides this, rectal examination should also be done, which will tell you about the involvement of the rectal mucosa and if there is any nodularity in the POD, if there are deposits in POD also. So after history and examination, a thorough examination, one should now have a differential diagnosis in mind. Now to corroborate your findings and to exclude the DDs, you have to further go for investigations. Among the investigations, first important thing is you go for an imaging. So imaging, you can do a transvaginal ultrasound with or without Doppler or transabdominal. You can go for higher modalities, MRI, CT, but the first choice is sonography. That too, a transvaginal ultrasonography is a most effective way of evaluating the adnexal mass, especially in the sexually active females. The TVS helps in characterizing the adnexal mass in terms of the size of the mass, its architecture, whether it is solid, cystic, unilocular, or multilocular. What is the wall thickness of this mass, whether there is presence of any septations, any papillary projections, what is the vascularity of this mass, and whether there is presence of any ascites. The transabdominal ultrasound is supplementary to TVS, especially when the mass extends beyond TVS view and you cannot fully examine the mass on transvaginal ultrasound. And also it is important in standardizing the USG reporting by using IOTA classification, GIRADS and ORADS also, which we will be discussing in the next talk. However, to just to tell you about IOTA, IOTA is International Ovarian Tumor Analysis. It was developed prospectively and externally validating using simple rules, which are the M rules and B rules, and the mathematical models are there, which are the logistic regression model and they basically helps in predicting the risk of malignancy. The advances in this IOTA classification is Adnex risk module and the simple rules risk calculator, which will be, I think will be discussed in next talk. So I'm not going into detail about these models. Another important thing in imaging is 3D USG and Doppler. So the malignant masses, as we all know, they have a new vascularization and they have an increased vascularity, which has a low resistance flow than the ovarian vessels. The 3D power Doppler angiography, it helps in mapping the vessel morphology of the tumor. It improves the detection of central blood vessels in the papillary projection and also helps in differentiating the benign and the malignant lesions. However, the combination of this TVS and power Doppler, it should be reserved for complex cases. It should not be done routinely for all the cases, but in some cases, this may aid in diagnosis. So, coming to another, after IOTA, there is ORADS, that is Ovarian Adnexal Reporting Data System. It was to optimize the ovarian cancer outcome while minimizing the unnecessary surgical procedure in patients who have a low risk of malignancy. So based on the standard lexicon, it incorporates all classes of risks and offers some management strategies for each risk category. So there are different risk categories, and accordingly we have to manage so that unnecessary surgical procedures are not done. Another is gynecological imaging reporting and data system, that is called GI-RADS. It is a reporting system which removes the ambiguity in TVS reporting of adnexal masses. And it also classifies the lesion according to their level of suspicion for malignancy. The sensitivity and specificity for diagnosing malignant tumor of GI-RADS is 92 and 97%. So these are the grades of the GI-RADS, which gives you a 0 probability of malignant to very likely probability of malignant as more than 20%. So now there are some other, besides this imaging, ultrasound imaging, there are other imaging modalities which can be used in differentiating the benign and malignant ones, and also characterizing the adnexal masses, which includes the contrast enhanced MRI. It is a preferred modality for an ultrasound indeterminate adnexal lesion. So where the ultrasound, while doing an ultrasound, we are not sure about the adnexal lesion, then we can go for an MRI, because it can differentiate between a simple fluid, an atypical fluid, whether it has a fresh blood or solid component. And it also better differentiates the cystic and solid masses, especially the endometriomas and teratomas. It has a sensitivity of 92% and a specificity of 85% in distinguishing a borderline and malignant ovarian tumor from benign tumor. Another modality is CT scan. However, CT scan do not characterize the ovarian morphology, but yes, in cases of advanced stage or to rule out metastasis, distant metastasis, it is a good modality to look for the peritoneal implants and the para-aortic enlargement and metastasis to other sites. Even CT chest can be done to look for pleural or pulmonary mets. And PET-CT can be used in evaluation of indeterminate lesions on USG or MRI, or in cases of recurrent ovarian malignant masses. Where there is recurrence, then PET-CT can be done. Now, once we have taken a history, we have done a good examination and have done the imaging also. Now we come to the other investigations. Besides the routine investigations, the important thing is to do a tumor marker analysis. So the most commonly used tumor markers is the CA125. The normal value of CA125 is less than 35, and it is elevated in 80% of women with advanced ovarian cancers. However, in early stage, only 50% patients will have a raised CA125. Because there are other conditions also where CA125 can be raised. So it is not a significant marker for detecting ovarian malignancy, because in other conditions like metastatic solid tumors of GI or breast, or uterine oration, endometriosis, tuberculosis, even pelvic inflammation, pregnancy, menstruation, it can be raised. Another very good marker, which has a better diagnostic sensitivity in early diagnosis of ovarian cancer, is HE4, that is human epididymis protein 4, which is a gene product of WFDC2 gene. The normal value of this marker is 60 to 150 mole per liter. It is overexpressed in 93% of serous and 100% of endometrioid carcinoma, and it is more specific than CA125 in ovarian malignancy. So HE4 measurement alone or in combination with CA125 can be considered for differential diagnosis of pelvic masses in premenopausal patients. Another marker is CA19.9 and CEA. These are the markers where we want to rule out the GI involvement also. So these markers can be done, and they are especially elevated in pancreatic, hepatobiliary, or gastric adenocarcinomas. But besides this, if the patient is a young or young age, premenarchal or early reproductive age group, we have to rule out the germ cell tumors also. So other biomarkers should also be done. So depending on the age of presentation, the marker should be advised. It's not that if a postmenopausal woman is coming and you are advising her beta HCG, alpha fetoprotein, and LDH. So depending on the age of presentation, the markers are advised. So in younger age group, one has to rule out germ cell tumors. So beta HCG, alpha fetoprotein, LDH should also be done. In dysgerminoma, beta HCG and LDH can be found positive, and endodermal sinus tumor, alpha fetoprotein can be raised. Choriocarcinoma, beta HCG is raised. In a mature teratoma, you can find alpha fetoprotein, CA125, and even LDH also raised. And in embryonal cell carcinoma, beta HCG and alpha fetoprotein can be raised. So these are the tumor markers which we routinely advise depending on the presentation of these masses, depending on the age. So LDH, alpha fetoprotein, and HCG should be measured in all women under 40 with a complex ovarian mass to rule out germ cell tumor. It's according to RCOG classification. Now, once we have taken history, we have known her menopausal status, whether she's premenopausal or postmenopausal. We have known her CA125 level, and we have also done the imaging. Now, important thing is to calculate her risk of malignancy, which is estimated by RMI scoring. So what is RMI? RMI includes CA125 levels, the ultrasound points, and the menopausal status. Among the ultrasound points, we take whether the mass is multilocular, there is presence of solid areas, there is presence of any intra-abdominal metastasis, there is ascites or a bilateral ovarian mass. So there are 4 types of RMI have been described: RMI 1, 2, and 3. RMI 1, 2, and 3 has a cutoff of 200, while RMI 4 has a cutoff of 450 because it takes into account the size of tumor also. But the commonly used RMI scoring is RMI 1. So if the ultrasound, there is no ultrasound feature suggestive of malignancy, then the score is given 0. If there is one feature, then a score is given 1. And if there are more than 2 features, then a score is given 3. Premenopausal score is 1 and postmenopausal is 3. So depending on this, we calculate the RMI score. So this I'm not going into detail. I think we are short of time. So coming to other multimodal tests besides RMI are ROMA, that is the risk of malignancy algorithm, which includes CA125, HE4, and the menopausal status. The cutoff taken is more than 1.31 in premenopausal and more than 2.77 in postmenopausal. Then there is a triple screen, which includes the GOF symptom index, CA125, and HE4. Then there is a Copenhagen index, which includes CA125, HE4 levels, and the age. Other ones are OVA and OVERA. But out of all these multimodal tests, after RMI, OVERA is the FDA approved, which is a second generation multivariate index assay, which includes CA125, transferrin, apolipoprotein A1, FSH, and HE4. They take a cutoff of 5. So if it is less than 5, then the risk of malignancy is low. However, these all tests are costly. So even a simple RMI, it is you can do always when the patient presents. So it should be done in all patients with adnexal masses. Now, important thing is whenever you encounter an ovarian cyst, the aspiration of ovarian cyst for diagnosis should never be done. Firstly, the diagnostic cytological examination of these ovarian cysts has a poor sensitivity of around only 25%. And there is chances of recurrence of these cysts again. And if it is malignant, then there is spillage and seedling of the cancer cells into the peritoneal cavity, which will affect the stage as well as the prognosis. So if we are suspecting a malignant ovarian mass, then the goal of preoperative evaluation should be to assess the exact extent of the disease, to assess the ability to tolerate surgery. The performance status of the patient is very important. The decision to make whether a primary surgery is required or patient will require a neoadjuvant chemotherapy, and to exclude a synchronous primary cancer and the possibility that the adnexal mass is due to metastasis from either extra-ovarian origin or a primary cancer is a GI, or it is a GI metastasis. So one should be very careful while we are suspecting a malignant ovarian mass. Now, a few words about the management algorithm depending on the age. So if we are considering the age group as children and adolescent, we know that the most common benign type of tumors in these are the simple cysts. There can be 60%, and there can be complex cysts, which can be either mature cystic teratoma, endometrioma, gonadoblastoma, cystadenomas, which can be serous or mucinous, or cystadenofibromas. There can be tubo-ovarian abscess, paratubal or paraovarian cysts. And among the malignant one, there can be sex cord stromal tumor, germ cell tumors, or epithelial tumors. So if the patient is asymptomatic or presents with pain or menstrual problems or precocious puberty, it is very important to do an ultrasound, see what type of cyst it is, whether it is a simple cyst or it is a complex cyst. Even if it is a simple cyst, then what is the size of the cyst? Whether it is less than 5 centimeter, more than 5 centimeter, or more than 7 centimeter. Because if they are smaller cysts, they are simple cysts, then we can go for a conservative approach, rescan the patient again in 3 months, and look for any increase in the size or change in the character of the cyst. But suppose if the patients with any adnexal mass presents with an acute emergency, then one should also suspect torsion. So imaging is done and the surgery should be done. The route, whether it is laparoscopic or laparotomy, depends on the nature of this mass and also the condition of the patient. Now, if we are dealing with adnexal mass in premenopausal women, then first we have to see whether it is a complex mass, it is a simple mass, or simple mass which is more than 5 centimeter or less than 5 centimeter. If it is a complex mass, then or a simple mass, we have to do an RMI score. If in complex mass RMI is more than 200, then go for another other imaging. And if suspicion of malignancy is there, then refer it for gynecological oncology review. Otherwise, if it is a simple cyst and needs surgical intervention, then one can decide depending on the character of the cyst, whether a laparoscopic surgery can be done or a laparotomy. But aspiration of the cyst, if you are doing, then be careful. It has a high recurrence. It should be contraindicated if suspicion of malignancy is there. However, if the patient is a case of malignancy and is not for primary debulking, then one can take biopsy from that mass and the patient can be referred for neoadjuvant therapy. In postmenopausal cyst, first of all, measure CA125, do a scan, calculate the RMI. If it is low risk, then you have to see whether the cyst is less than 5 centimeter or more than 5 centimeter, or there is presence of any other symptoms like patient has pain or pressure symptoms or anything, then accordingly you have to do management. If the RMA is more than 200, then you have to keep a high index of suspicion of malignancy and go for other modalities and do a gynecological oncology MDT review also. So to summarize, adnexal masses can be divided according to morphology as non-septated or septated clear cysts. The cysts can be with internal echoes, solid tumors can be there, or it can be a septated cyst with solid component. But whatever is the type of the cyst, it is very important to know the organ of the uretion, because if you know the organ of the uretion, then you can further treat that adnexal mass. So the optimal treatment requires the knowledge of exact nature of the mass. Thank you.
Thank you so much,
you.
ma'am.
Thank you,
for-
Dr. Jyoti. It was a wonderful lecture and you have summarized it so beautifully. And just for the PGs, I would like to say that they should, staying in India, they should always think of tuberculosis also. TUMAS, it can present at TUMAS also. So in the history also, it's very important to take the history of Cox. Secondly, that X-ray chest should be a modality. Thirdly, I think pap smear should always be taken. Pap smear, because as you've said that fallopian tube carcinoma, that can also present as this thing. And sometimes you can find the malignant cells in the pap smear also, or the liquid-based cytology. So these were the few things. And of course, while examination, I think one should always examine the breast, because I had a patient who had a breast mass and she had a big ovarian mass, turned out to be Krukenberg along with the breast tumor also. So examination of the breast, that is also very, very important. So these were just the points I wanted to say. Otherwise, it was a very good, excellent lecture. Thank you.
Thank you,
Dr.
ma'am.
Dr. Meena would like to say something. Dr. Meena Samant.
Yeah. Actually, it was such a extensive thing. It was a whole revision, and so I felt like a student learning from Dr. Jyoti. And I actually
Yes.
agree with Dr. Harsha Kular, the inputs that she has given. Yeah, you do find some atypical things like those also once in a while. And especially recently, I have actually encountered tuberculosis where we've had even in young patients. I know. So I was discussing with someone, and they said even post-COVID, that has been a scenario. They also have found a rising incidence, probably, or maybe we've detected it by chance. That in even one elderly lady, postmenopausal, where it was a cyst, but then ascites, and the ascitic, because of other things, we did suspect tuberculosis because the general outlook and all, and then they did a ascitic tap, and that turned out to be tuberculosis. So she is now undergoing ATT. I think in next few months we will be doing a repeat CT or ultrasound to see the nature of that adnexal mass, whether it's still there, needs to be treated, or it too has resolved with this ATT. Thank you, ma'am. It was a very refreshing and wonderful lecture.
Thank you so much, ma'am, for the wonderful overview and how to process our thoughts regarding adnexal masses when we receive such patients. I guess we'll move now to our next session. We'll move to our next session regarding IOTA group application of imaging and adnexal masses. I'll like to invite Dr. Gangadhar Sahu sir. He's the president of ISOPARB chapter 22-23, retired professor and HOD OBGY, VSS Medical College Barla, Dean IMS and SUM Hospital Bhubaneswar for more than 6 years. He has been awarded Best Teacher Award in 2013, Best Orator in 2013 and 16, and Papin-Nicol Award 2023 for contributions on prevention of CA cervix. He has operated around 1,000 gynecological cancers. He has got many publications in national and international journals. He has contributed in many textbooks, written 2 books on My Thoughts, Volume 1 and 2. He's a passionate teacher, motivational speaker. I'll now invite Sir to invite our speaker for this session, Dr. Deeksha Rastogi, ma'am. I'll ask Dr. Mala, ma'am, to give our inputs on this session. She's our own senior consultant and professor. Gripmer, she's a gynec endoscopic and robotic surgeon in our Sir Ganga Hospital, New Delhi. She's the Vice President-elect ISOPARB 2023-24 chapter. Past President of AOGD 2020-21. Ma'am heads the gynec onco department in our hospital. She's a gynec endoscopic surgeon and in robotic surgeries.
Thanks, Dr. Anuva, for the kind introduction. It's my pleasure and privilege to introduce the speaker of the evening, Dr. Deeksha Rastogi. Dr. Deeksha is a Vice Chairperson and Senior Consultant, Department of Ultrasound at Sir Ganga Hospital. And she has professional membership of IRA and IFM. And over to you, Dr. Deeksha, for your scientific deliberation on IOTA group application on imaging in adnexal masses and update. Floor is all yours.
Just let me. Okay. Thank you so much, ma'am, and thanks for giving me this opportunity to talk in this webinar. I'll be talking upon the IOTA risk models, including Adnex for predicting malignancy in adnexal masses. In our daily practice, we see lesions like this, and we all wonder how to report them. And we see a lot of reports reported them as complex cyst or heterogeneous masses. And this is not how one should be giving the final report. And I hope by the end of my talk, we are wiser on how to report these masses. So how do I remove this? I'm not able to have a full screen.
Ma'am, we can see the full screen.
Yeah, but I can see the. Okay. So ovarian cancer is a leading cause of death in women diagnosed with gynecological cancers, with most cases diagnosed at an advanced stage. So the idea of doing this imaging is to pre-operatively characterize the lesions so that the management can be done accordingly. So International Ovarian Tumor Analysis Group is a multi-center collaboration whose aim is to design tools for pre-operative diagnosis of ovarian cancer. It was founded by Professor Dirk Timmerman, Professor Tom Boone, and Professor Lil Valentin in 1999. They developed standardized terminologies to describe the ultrasound features of the adnexal masses and then correlated them with histology. To enhance the accuracy of these diagnoses, simple rules and mathematical models have been developed, which includes the IOTA group, the LR1 and LR2 models, IOTA, Adnex, and even ORADs. So I'm going to go one by one and first describe what are the standard terminologies. So what do we call an adnexal lesion? It is a part of an ovary or an adnexal mass that is judged from an assessment of ultrasound images to be inconsistent with normal physiologic function. So what are the various terms and definitions? And transvaginal ultrasound is the modality of choice. So we have to define the lesion based on whether it is unilocular, multilocular, what kind of a cyst content it has, whether it has any solid material or papillary projection, what is the vascularity, is there any shadowing, or there is ascites. What do we call a unilocular lesion? A unilocular lesion is a cyst without septum, solid part, or papillary structures. We should not confuse a normal ovarian stroma as the solid part of the tumor. You can see it in this image. It is a very thin walled regular cyst with no echos within it. There are no solid material and no septi. So this is a unilocular cyst. A unilocular solid cyst is a cyst with a measurable solid component, as can be seen here. If the solid part contains small cysts, the mass also can be called a unilocular solid. A multilocular cyst is when there is at least one septum present and the septum should cross from one wall to the other, and there should not be any solid component in it or a papillary projection. If there is a solid component as seen here, or again seen here, then it is a multilocular solid, or there can be more than one papillary projection. A solid tumor is one when there is more than 80% of the cystic lesion or the mass is solid, and a solid tumor may contain papillary projections protruding into the smaller cyst. Now we come to echogenicity. It can be anechoic when it is absolutely black in color. We can have homogeneous low-level echoes, like we see in a mucin producing tumor. We have ground glass as seen in endometriosis. We can have reticular pattern as seen in hemorrhagic cyst, and we can have various echogenic lines or nodules, which we see in a dermoid. So here you can see again a thin wall unilocular cyst, which is anechoic. This is low-level echoes of mucin, and this is ground glass echo of endometrioid. And this is how a hemorrhagic cyst looks like. There is a reticular pattern here, and a typical dermoid with a Rokitansky nodule, and these thin lines, which is the hair. So how do we measure a papillary projection, or what is a solid component? It is a structure which exhibits high echogenicity, suggesting the presence of tissue. It should be at least 3 millimeters or more than that. We should not confuse blood clots, mucin, or fat as solid tissue. When we press upon the lesion through the transvaginal probe, we can see the contents moving. Papillary projection is any solid projection into the cyst cavity, which is more than 3 millimeters. And this is how we measure. This is the base and this is the height. So we need to measure it from the base till the height, and that is what a papillary projection should be. Like here, this is only 2 millimeters. So this is just a wall irregularity, whereas here it is a solid lesion. Irregular means an irregular internal wall of a cyst or irregular outer contour of a solid lesion. If there is a solid papillary projection, then the wall is irregular by definition. Like for here, you can see this is a septa, the multiple papillary projections, so this is irregular. So we need to also give put color Doppler and see the vascularity. For this, again, setting should be very good. The PRF should be between 0.3 to 0.6, and the Doppler setting should be such that the artifacts are not there. If you're not sure of what grade it is, we give the worst score. So we have 4 grades, 1 to 4, where 1 is no flow, that is no color pickup at PRF of 0.3. Minimal that we have to really look. For example, in this, a septa had just 1 speck of flow within it. This is moderate, which is grade 3, and this is strong flow. Shadowing is the loss of acoustic echo behind a sound absorbing structure. Here you can see an echogenic nodule and marked posterior acoustic shadowing. This is usually a sign of a benign lesion. Fluid which is seen outside the pouch of Douglas is called ascites, which is normally seen in a malignancy. So now we first come to the simple descriptors defined by IOTA. So this is basically pattern recognition. That means the lesions are really obvious. When you look at them, we are very sure that this falls into a particular group. So 50% of the masses fit into this category, of which we have endometrioma, dermoid, simple cyst or cystadenoma, physiological cyst like hemorrhagic cyst, and malignant tumor with ascites. And this is in post-menopausal women more than 50 years, and the CA-125 level should be more than 100. So as I've already shown, this is an endometrioma, a uniform unilocular lesion with ground glass echogenicity in a premenopausal woman. This is a typical dermoid. This is how a unilocular anechoic lesion looks. It should be less than 10 centimeters for us to consider it to be benign. This is how a hemorrhagic cyst looks like with reticular septae within it. And this is a malignant lesion with increased vascularity and ascites. So this, in a postmenopausal woman, we can again put it in a simple descriptor and call it a malignant lesion. So if we are not sure about simple descriptors, then we go and apply simple rules. So IOTA has given us 5 benign features and 5 malignant features. So what are the 5 benign features? B1 to B5. B1 is a unilocular cyst. B2 is presence of a solid component, which should be less than 7 millimeter. Presence of acoustic shadowing is B3. We can have a multilocular smooth tumor, but the largest diameter should be less than 10 centimeters, which is B4. And there should not be any vascularity present. That is, the color score should be 1. So if one or more of the B features are present in the absence of M feature, it is rule number 1. Sorry. So what are the 5 malignant features? M1 is the irregular solid tumor. M2 is presence of ascites. M3 is at least 4 papillary projections. You can see the septa and there are papillary projections here, which should be more than 7 millimeter. This is an irregular multilocular solid tumor with largest diameter 10 centimeter, which is M4, and marked increased vascularity is M5. So rule 1 is if the mass is classified as benign, if one or more of the B features are present in the absence of M feature. Rule 2, if malignant features are present in the absence of B feature. And it is inconclusive if both M features and B are present, or if none of the M or B features are present. So it has a 92% sensitivity and 96% specificity in differentiating benign from malignant lesions. But we are still uncertain in 25% of the cases, and we need to use further index. So we have mathematical models given by IOTA, which we use. IOTA Adnex is the next which we use, but I'm just going to tell about other mathematical models, which RMI ma'am has already mentioned. Then we have LR1 and LR2, which are logistic regression models 1 and 2, and IOTA Adnex. RMI ma'am has discussed already, so I'll just go ahead. LR1 and LR2 was developed in the year 2013, and they were used to predict the likelihood of malignancy. LR1 had 12 predictors in it, whereas LR6 had the first 6. And so we don't really have to get worried that there are so many predictors or how to use them. There is an app given by IOTA. We can just go on that app, and the app is for simple rules for LR1 and LR2. Whatever findings we get, we just put them on the app, and it will calculate for you which category the lesion fits into. The main one which I'm going to discuss here is IOTA Adnex, which is assessment of different neoplasias in the adnexa. This was developed in year 2014. It is a multi-class model to distinguish benign from malignant lesions and to suggest the stage of malignancy. The calculation is done with or without CA125. There are 3 clinical features and 6 ultrasound parameters. The results are interpreted as benign, borderline, early stage primary, late stage primary, and secondary metastatic cancers. So when you go online, there is IOTA Adnex app. So when you type IOTA Adnex, this is something like this will open, and again you put in your findings. It has 3 clinical and 6 ultrasound parameters. So age of the patient, whether it is a referral from a onco center or not, what is the maximum diameter of the lesion, maximum diameter of the largest solid part, whether 10 locules are present or less, the number of papillations 0 to more than 4, acoustic shadow yes or no, ascites yes or no, and serum CA125, which is optional. You can put, if you don't have the values, you can still calculate it. CA125 level helps in predicting the stage of the disease. This is how a chart will come when you put on your various values. Here it is showing that this chance of a lesion to be benign is 99.6%. So we can be very sure that we are dealing with a benign lesion. So when we are not sure after our simple descriptors or simple rules, we can apply it next. And then there is another classification given by ORADS, which is Ovarian Adnexal Imaging Reporting and Data System, given by American College of Radiology. It is along with the IOTA group to determine the risk of malignancy. In this, they're also telling us how to manage the patient, and the risk prediction model they have used is of ORADS. So this is an article of ORADS, and if you read this, every description is given very well in it. And this is the chart. Yes, it looks very complicated, but it's not. We should have this chart with us while we are scanning, so that it's very easy to fit in. More than that, there is this app given by ORA, by ACR, and it's very easy. I'll show you in the end. And again, you just keep on putting your descriptors in it, and it tells you the prediction of the risk of the lesion. So this is the lesion. You can see in the first column, it is 0 to 5. There are 5 grades to it, 0 being incomplete evaluation. Then we have lexicon descriptors, which are based on what I've already described. The only differences in the grade 2 category, they've also added 3 lesions which are outside the ovary, which I will just tell you. And then there is management depending on the premenopausal or the postmenopausal status of the woman. So incomplete evaluation means that because maybe your ultrasound was not complete, you were not able to do a transvaginal examination, or patient did not let you do a transvaginal because of pain, there was a lot of gas. So you go on to another modality like MRI, or maybe call her for a repeat ultrasound later. So this falls into a 0 category, that is incomplete evaluation. Grade 1 is normal or physiological, like what we see a follicle or a luteal cyst. Grade 2 is almost certainly benign with less than 1% chance of malignancy. 3 is low risk, 1 to less than 10%. 4 is intermediate, 10 to less than 50, and 5 is high risk, more than or equal to 50%. And this is how the management is told, that if it is 0, you do a repeat ultrasound. For ORADS 1, which are physiological, we not require any follow-up. For ORADS 2, either no follow-up, or we can just take a second opinion by an ultrasound specialist. In ORADS 3, we repeat the ultrasound by a specialist, do an MRI, or refer to a gynecologist. In ORAD 4, same thing, plus we can also include a gyne-oncologist. And ORADS 5, definitely we refer the patient directly to gyne-oncologist. I'm going to show you a few cases so that you understand better. So this is how a typical corpus luteum cyst looks like. You can see the crenated margins of the collapsed cyst, and when you put a color, there is marked increased vascularity all around it. So we should not confuse it with any other kind of lesion. This is very much normal. The size is less than 3 centimeters, and this is a corpus luteal cyst. These are the various types of hemorrhagic cyst. Here, I'll just show you a video. You can see the thin septi within it, like a reticular pattern. The cyst is less than 3 centimeters, again physiological. These cysts I've already shown you, again a reticular pattern and a retracted clot, which is again a typical of an hemorrhagic cyst. These are various kind of endometriosis. All have ground glass echoes. Some may even have a septa. So we should not again confuse it with a multilocular solid tumor or anything, because there is no solid component. You can see the fluid blood echo level also in it. So these are all different kind of endometriosis. These are different kind of dermoids. You can see the hallmark is posterior acoustic shadowing, which and a cyst which may have different looking ecotexture. We can have it like here, you can see it is more black than this. So yeah, so it can be different level of fat, hair, and rocky Tansky nodule, tooth. So, but all of them are typical dermoids. Then the 3 parameters, 3 other lesions which they have taken in ORADS 2 is parovarian cyst, hydrosalpinx, and peritoneal inclusion cyst. So if we see a dilated tubular structure outside the ovary, then we know it's a tube. As you can see here, you can follow this whole structure as a tubular, and the tube also has incomplete septi and has a typical cogwheel appearance on ultrasound on transverse imaging. So while doing the transvaginal scan, we must make sure that the lesion is outside the ovary and not inside. This is how a peritoneal inclusion cyst looks like. You may confuse it with ascites, but what you must see that the ovary is seen at the periphery of the cyst, or it could be embedded within the cyst fluid, but there is no indentation with the ovary. So, and you might find septae within it, and this is benign, and this is normally which we see post-operatively because of additions. And this is called peritoneal inclusion cyst, and all of them will fall into ORADS 2, that is less than 1% chance of malignancy. This is parovarian cyst, this is ovary, and this is a cyst lying outside the ovary. So this is a parovarian cyst. Now I'm going to show you a few cases, and I hope we'll be able to categorize them better now. So this was a 26-year-old lady who presented with pain in the lower abdomen. And while scanning, we saw a unilocular cystic lesion. It had internal echoes. There is shadowing present. There is no internal vascularity. And with the help of simple descriptors only, we can say that it's a dermoid. What all simple rules does it have? It is a unilocular, there is acoustic shadow and no blood flow. So B1, B3, B5. So it has 3 benign features and it has no malignant feature. When I put these values in IOTA Adnex, we put the age of the patient. Yes, the referral is because we work in Ganga hospital. We have gynae onco referral. We put in the maximum diameter of the lesion and other modalities, features given, and the 99.5% chance of it being benign. And it falls in ORADS 2 classic category of a classic benign lesion. So we are very sure on our ultrasound that this is a benign lesion. Coming to another patient of a 44-year-old lady who came with abdominal distension 2.5 months, not associated with pain or vomiting, but see her CA 125 levels are 12,764. So when the patient came for imaging, you can see this is so this is on transabdominal imaging. We can see a large solid lesion, solid cum cystic lesion in the right adnexa. This is a lesion in the left adnexa. So she has bilateral ovarian masses. The lesions are absolutely solid in the left side with a small cystic component at the periphery. You can already see marked ascites. This is on transvaginal imaging, a large solid component. Even the wall of the cyst is very thick and irregular. Marked ascites seen on transvaginal imaging. There is marked increased vascularity and on TVS and even on transabdomen. So by looking at this, now can we tell what kind of lesion it falls into? So, and this are simple descriptors will not help us because this is not a postmenopausal woman. So by putting simple rules, we can say, yes, there is a solid lesion. So it is M1. There is increased vascularity. It is M5. And there is ascites. It is M3. So it has 3 malignant features. So it falls into malignancy. When I put all these values in the IOTA Adnex model, it gave me the risk of malignancy as 99.9%. So we are very sure this is a malignant tumor. It is also characterizing it and giving us a stage of the disease. So this falls into stage 2 to 4 disease. That is 98.2% chance of it being a stage 2 to 4 disease. And with ORADS 5, in ORADS 5, we have any unilocular or a multilocular tumor of any size which has a solid component within it. So this falls into ORADS 5. So what was the diagnosis of this tumor? It was a poorly differentiated carcinoma compatible with high-grade serous carcinoma. Now, next case is a 25-year-old lady who came with severe pain in lower abdomen since 4 to 5 months. She was trying to conceive. She came with us with these values of CA 125/14 and a LDH, which was a little high. On scanning, we found that this is a right ovary. You can see it's fine. There is there are 2-3 follicles and there appears to be a clear cyst. This is 3.5 centimeters in maximum diameter. So I will not call it a follicle. I will call it a simple cyst. And because it is more than 3, so this falls into a IOTA B1 category. That is a unilocular simple cyst. But when we scanned the left adnexa, we saw a large solid mass. Most of the lesion was solid, had some cystic component within it. Along with that, it also had some calcific foci. There was marked increased vascularity and there is ascites. So again, our simple descriptors we can't use that because this is not a postmenopausal woman. The lesion is solid, so it has 3 M features, that is M1, M2, M5. When I put these values in IOTA Adnex, it gives me 0.3% chance of malignancy. It's only 9% chance of it being benign. And there is a 63.9% again of stage 2 to 4 disease. So this tumor turned out to be a sclerosing tumor of the ovary, and patient can be then managed accordingly and sent to a gynaecologist for further management. Another 26-year-old lady who came with pregnancy had CA 125/78 and was just sent to us as a follow-up of a right ovarian cyst. So when we examine this patient, you see this fluid is not ascites. It was a large solid cum cystic mass lesion. I'll just show you all the images. So there is a pregnancy here. This lesion is more than 20 centimeters. It's a solid cum cystic lesion. There is a large frond-like solid mass with multiple foci of calcification. Now you will say there is shadowing, so why can't it be benign? But when we put color, there is marked increased vascularity. The septae here are showing multiple papillary projections. There are multiple, more than papillary, there are also solid lesions throughout. So again, our simple descriptors we can't use them. So it has again M3, M4, M5 features of simple rules. When we put this in IOTA Adnex, very high chance of malignancy, 96.8, with 40.2 chance of stage 2 to 4 disease. And this tumor turned out to be a immature teratoma, grade 3 in a 26-year-old female. Sorry, I have most of the cases of very young females. This is a 23-year-old lady with pain abdomen, menstrual irregularity, abdominal distension, and a high CA 125. So this is the first image. The patient came for whole abdomen ultrasound, and this is the area of liver. I'm in the right hypochondrium right now, and you can see these hyperechoic lesions in the peritoneal cavity along the. So these are deposits along the peritoneum. You can already see ascites here. This ascites even has echos within it. When we come down to the adnexa, we see a large solid mass which is more than 15.6 centimeters. There is marked increased vascularity, as you can see. So this is strong flow. Again, so we don't have to really put our mind to what it falls into, because of the deposits, it already becomes ORATS 5, and this patient should be sent to a gynae-oncologist. And IOTA Adnex tells us 92.9% chance of malignancy with very high stage 2 to 4 disease, and this turned out to be a high-grade serous cis adenocarcinoma with metastasis. This is a 28-year-old lady who came with history of cyst in left adnexa. So in this video, you will see this huge multilocular cyst, more than 10 locules. They do not appear to be any, again, I'm going to play there are no solid components. It has smooth walls. There is no irregularity. This is a trans-abdominal image because the lesion is so huge. It is more than 18 centimeters. So what category will this lesion fit into? It will not fit into simple descriptor because it is more than 10 centimeter. In simple rules, what can we say? Because by looking at it, it looks like a benign lesion, but again, with simple rules, the only simple rule it has that it has no flow, so only B5. And when we put IOTA Adnex, it tells us that it is 80.4% chance of it being benign. But when we put ORAS, it puts it into an intermediate risk category. Why? Because first, it is more than 10 centimeters. That is the only criteria for it to fitting into ORAS 4 because of the size of the lesion, and which makes it 10 to 50% chance of malignancy. But this tumor turned out to be a mucinous cyst adenoma, a benign tumor. So I'm going to show you another. So this is an app of ACR, which I told you before. So it is with this tumor only. So we're going to put these findings. So this is ovarian, non-physiologic lesion, other lesions, cyst with no solid component, smooth margins, multilocular, 1 to 3 with more than 10 centimeter color score, and no ascites. So it turned out to be a ORADS. Sorry. It was an ORADS 4 intermediate risk category. So this is just to show you that app. You can download that app on your phone and you just have to put these descriptors and you'll be able to tell what category of lesion it is. Thank you. I would really like to thank my resident, Dr. Varun, without whose help this talk would not have been possible. And thank you so much for giving me this opportunity to talk. Thanks once again. Thank you, ma'am.
Thank you, ma'am.
Sir, Dr. Gangadhar Sahu, for your expert comment.
Thank you, Dr. Mala. Actually, very much thankful to ISOPARB chapter of Delhi for giving me this opportunity to chair this beautiful session. So, first thing I want to say that many congratulations to Dr. Rastogi for a beautiful presentation. Why I say beautiful presentation? Because for the diagnosis, she has a very clearly described the different ways of imaging, particularly as regards the adnexal mass, which is actually a headache for the gynecologist to diagnose. And most important and interesting part that I appreciate her correlation with 6 or 7 cases with those findings, starting with the imaging, then the color Doppler, then the simple rules, ORADS, everything. So when we put together, chances of error will be less. Therefore, even if the gray zone or the gray area, that is the inconclusive, is quite high number, that is 25%. But that is the area or the cases which should be under our focus and vigilance. So proper follow-up for those cases for at least 6 months to 1 year, then we can clinch the diagnosis and treat them early. So thank you again, Dr. Rastogi, for a beautiful presentation, which I will remember it for throughout my life, because very rarely I come across such a presentation. I am too much impressed. Thank you, Mala, that you have given me this chance. Unmute.
Dr. Anuva, I think we can move on to the next session of the evening.
Yes. We go on to our next session now, which is regarding the review of literature, society guidelines regarding the imaging of adnexal masses. I invite Dr. Chandra ma'am, gynec endoscopic and robotic surgeon and specialist in adolescent health. She's a senior consultant in Ganga Hospital, treasurer of NARCHI, Delhi branch 2002 and 24, treasurer IMS Delhi chapter 2007-2009, joint secretary ODG in period of 2008-2009, vice president ISOPARB Delhi chapter 2013-2020, vice president of IMS Delhi chapter at present, editor of AOGD 2021, and president of ISOPARB Delhi chapter 2021 till date. Dr. Chandra ma'am, I'll invite.
Yeah, thank you, Dr. Anuva. I think you have to invite another chairperson also, Dr. Modi. I think you invite first and then I'll introduce the speaker.
Yes, ma'am. I'll invite Dr. Rahul Modi, sir, consultant Gynaecology at Ganga Hospital. He has got many awards. In 2029, he received Shingo Fuji ICGS Young Doctor Award in Gynec Onco, 2020 Shashikant Lele Fellowship Award, Roswell Park, US, 2020 Guest Young Doctor in Berlin. I'll invite sir. Ma'am, I think we can invite our speaker now.
Yeah. Thank you, Dr. Anuva. Now, by this time, we have learned a lot about the adnexal masses, how to evaluate and how to do diagnosis. So Dr. Deeksha has beautifully described and showed with the images also. So now we have to learn about the society guidelines regarding the imaging of adnexal masses. For that, I am going to invite a very young and enthusiastic speaker, that is Dr. Vaishali Paliwal. She is associate consultant from the Nanavati Max Institute of Cancer Care, and she's MCH Gynecological Oncology from the Tata Memorial Center. And she's a trained robotic surgeon. And she has a special interest in the minimal access surgery in gynae oncology, extended pelvic surgeries for the recurrent and advanced gynecological cancers, and precision oncology. So now it's over to Dr. Vaishali to speak regarding the guidelines, society guidelines. Dr. Vaishali is around. Dr. Vaishali, can you hear us?
She's around.
Yeah.
Dr. Vaishali, please unmute yourself.
Hello. Am I
Yeah,
audible?
Dr. Yeah, now you are audible. Yeah.
So just hold on.
We can't see your slides.
Yeah, just. Can you see the slides now?
No, ma'am, not yet.
I am sharing my slides.
Yeah.
Can you see the slides now?
No, not yet. Mr. Vinod can help you out. Mr. Vinod, are you around?
Yes, ma'am, I'm here.
Yeah, because
Please
you
help.
help her out.
Please help Dr. Vaishali.
Dr. Vaishali, are you share your screen, please? Are you able to see the arrow?
See now?
Ma'am, there is a
Not
green
yet.
arrow in the lower of the screen.
There is, I am going to rejoin the webinar actually.
Yeah, okay.
Because I'm having a lot of echo.
Are you with laptop?
Vaishali can forward the slides to Vinod. I think then Vinod can.
Yeah, same. I think she's unable to share the slides.
So she can.
Mr. Vinod, if you are around, you can take her slides.
Maybe
And-
WhatsApp me slide or group.
You don't have slides?
I think she has started sharing at the screen.
Okay. Yeah.
That's it.
Yeah, now we can see the
We
slides.
can see. Yeah.
But it's not the
Slideshow. It will come into
yeah,
slideshow.
yeah. She has to do the slideshow. Yeah, now we can see your slides. But it is not full screen.
Now is it full screen?
Not yet.
Not yet.
I'm going to click on the play.
Play at the center of your top screen. Yeah, इसमें play है ना बीच में.
I don't know why can't I play. Okay, are they now visible?
Yeah,
The
ma'am, it is
slides are
visible.
Play use. There's a play there, na? Play that. Yes.
ma'am. It's okay now.
Yeah, now it's okay. Yeah, absolutely.
Hello, am I audible?
Yeah.
Yeah,
you're
you are
audible.
audible. Yeah.
So actually, I think I am having a lot of echo, but I'll continue because we are well beyond the stipulative time. Okay. So good evening, everyone. And thank you for giving me an opportunity to present in this webinar. And I would like to thank the team of Ganga Hospital, Dr. Mala Srivastav, and my esteemed colleague and dear friend, Dr. Rahul Modi. So my topic was to review the literature and the society guidelines. So I'm going to quickly, I don't know, it's hanging. My computer is not responding.
Can't hear you.
Now it is okay. So I'm going to quickly, go upon the evolution, how the Adnexal mass characterization systems they evolved. And then what are the guidelines, the current guidelines, and how did we reach there since the 1990s? So why it is important to, characterize the adnexal masses? Because of course, we want to detect the ovarian cancer, all the malignant masses early, and so that we can optimally manage our patient, reduce the unnecessary interventions, unnecessary referrals, and yeah, of course, not to miss any kind of ovarian cancer. Now, the differential diagnosis, the types of adnexal masses, this has already been discussed by Dr. Jyoti. Now, the evolution of the adnexal classification system. So it is since 1993, it started with the Kentucky Morphology Index, and now what we have is an URAD system on the basis of BIRADS and PIRADS. So what I want the students to understand is that these classification systems are divided into two types. So one are the pattern recognition systems, which are based on the morphological indices of ultrasound, MRI, or CT scan. And one are the risk prediction algorithms like the RMI, like the ROMA, or the IOTA Adnex model. So the starting of characterization of adnexal masses was by the Kentucky University, by the Kentucky Morphology Index, that included the tumor volume, the wall structure, and the septal structure. So I'm not going to go into the details of the volume, septal structure, wall, because that has also already been explained by Dr. Deeksha. Okay, but this was one of the first systems for characterization. And it also formed the basis of the Kentucky screening trial for ovarian cancer, which initially demonstrated a stage shift and survival benefit by ultrasound screening. The drawback was that it was validated in a single center and there was not a wide acceptance of this model. Then came IOTA. So in 2000, IOTA group, they decided that they want to conduct a multi-center prospective study to define the characteristics of adnexal masses, which can accurately divide them into benign or malignant. And therefore, they gave the IOTA terms, which were standardized terms to describe those adnexal masses. The procedures of ultrasound, how to describe, how to do the particular ultrasound, how to characterize those masses. It was a multi-center randomized study. And it was an effort to bridge the subjective variation that is there among different sonographers. It included the standard B mode imaging of the ultrasound and the color Doppler. So all this has already been covered, but what I want to tell, they defined that what exactly was a papillary projection, what was a septa, what was a complete septa, incomplete septa, and all the features which have already been described. So based on these IOTA simple rules in 2008, they published their B rules and M rules, the benign and the malignant rules, on the basis of which they categorize all these adnexal masses. So these rules were to guide the young sonographers, to reach the level of the expert sonographer. Of course, it's difficult. These rules, they cannot replace the expertise of experienced sonographer, but it was an attempt to conclusively define those adnexal masses. And as we have already seen, we have already discussed these B rules and M rules. If more than one feature of B benign, more than one M feature malignant, and if none of the features are present or both features, then it becomes inconclusive. So these simple rules are conclusive in around 75% of the adnexal masses. So the postgraduates should know that these are very good rules, and they're going to classify 75% of the adnexal masses. They're very simple, which have already been discussed. I'm not going into the details. So that was the IOTA simple rules. Now they cannot replace expertise and they cannot replace the poor quality of the ultrasound machines. Based on these IOTA simple rules, they were incorporated into these regression models, which included other parameters like age and this presence of purely solid tumor, color score, examination findings, and they gave a probability of the lesion being malignant or not. So both these LR1 and LR2 also, they did well. So all the simple rules and the LR1 and LR2 models, they were extensively validated, and still to date they are validated in different parts of the world, and they have been found consistently to conclusively identify all the adnexal masses, around 80% of the adnexal masses. So whenever we talk of evidence-based approach to characterize adnexal masses, simple rules do have a place. Now the simple rules risk calculator. Now the calculator included another additional parameter in these B and M features, and that was whether the ultrasound examination has been done at an oncology center. Okay, whether it was specialized center for characterizing these adnexal masses. Why it was included, we will come to that. Now, parallel to the development of these morphological indexes, there was development of the risk algorithms also, which included other parameters like the age of the patient. For example, the RMI already been discussed, whether the patient, but it includes whether the patient is premenopausal, postmenopausal, the ultrasound features, which have each a point of being multilocular, solid areas, metastasis, ascites, and bilateral lesions. Now, I want the students to understand that these 5 features are very important features. In your daily clinical practice, you have to remember these features. They are suspicious features, and RMI was in fact appreciated for including these features. So the cutoff for RMI to referral for a gynae oncology center, it was taken as 200. At a cutoff of 200, the RMI had an 85% sensitivity and a 96% specificity for correctly diagnosing a suspicious adnexal mass. Now, you all know there are limitations of MRI because it is based on the CA125. So it is not going to perform well in the premenopausal women. It will have a low sensitivity to differentiate between early stage and borderline tumors. And of course, there is no quantification of the risk of malignancy that an adnexal mass can have. And after that, subsequently, there have been a lot of modifications. RMI 2 came, 3 came, 4 came, but RMI 1 is the best to differentiate benign for borderline tumors. In fact, it is best to differentiate the serous borderline tumors, which are more aggressive than the other varieties of tumors, for the benign tumors. So RMI 1 is the one that is in use, and that even the RCOG guidelines till date, I'm not aware of any revision if it has happened, but the 2011 guidelines that have been published, they still incorporate the RMI 1 as a basis to characterize the adnexal masses and appropriate referral pathways. Then parallel to the RMI, ROMA was also developed, which included CA125 and HE4, but there was no particular advantage of this ROMA. And there have been, again, meta-analysis and systemic reviews, and they have demonstrated that RMI and ROMA have similar diagnostic performance. And though HE4 is considered to be more specific, but it doesn't have any advantage over RMI. In fact, to date, CA125 is the most important marker that has the maximum sensitivity and specificity for diagnosing ovarian cancer, despite it having low sensitivity in the premenopausal women. So after all these simple rules, then they were extensively validated. So the study was done then when all the adnexal masses, the simple rules were applied to the masses. 77% of the masses, they were conclusively identified, whether benign or malignant. The rest of the masses, they were subjected to subjective assessment, RMI, logistic regression 1, and LR2 models. And subsequently, the sensitivity and specificity are demonstrated. So the simple rules, the model is that whenever an adnexal mass is presented, you first apply the simple rules. And if they cannot classify the mass as either benign or malignant, it's an inconclusive, then you have to triage those masses and you have to send to an expert sonographer, experienced sonographer. Now, all these validation, all these prediction models are actually developed because we want the masses, to develop systems which are generalizable, which can be applied across all centers, and they're not related to the experience of the sonographer. Again, as I've told you, this IOTA models, the simple rules, RMI, and all those, they have been extensively validated. across multiple centers. There has been temporal validation in the centers where it was developed, external validation in new centers. The results are generalizable. It's a good triage method. 80% of the masses can be divided into benign and malignant. And overall, it does reduce the referrals. Again, after even this IOTA simple rules and the RMI and all, to simplify further the young sonographers and young gynecologists with special interest in sonography, there were simple descriptors which included only 4 benign features and 2 malignant features. So there I'm not going in the details, but there was a 3-step strategy. You first apply the simple descriptors. If you cannot classify, you go to the simple rules. And if you cannot classify even by the simple rules, you go to a subjective assessment by an experienced sonographer. So all this was based, again, these systems heavily on pattern recognition. Now, to overcome the issue of pattern recognition, because again, pattern recognition depends upon the expertise of the sonographer, the IOTA Adnex model was developed, which has been already discussed by Dr. Deeksha extensively. In fact, I was thankful she included a lot of pictures because I really don't have a lot of pictures in my presentation. So the Adnex model included 3 clinical parameters and 6 ultrasound predictors were there. And they were, as she showed, they were combined in an app, and they give a percentage risk of a particular mass being benign, borderline, stage 1, stage 2, 3, 4. So it was a very good it is a very good model, and it has a diagnostic accuracy almost similar to expert sonography. And the important thing is that it is subclassifying tumors even further, not just benign and malignant. It is subclassifying into stage 1 to 4 and even borderline tumors, because all the previous, the IOTA, the simple rules, they cannot classify, they cannot differentiate between a benign and a borderline tumor, which is actually important in daily clinical practice, because we can offer fertility preservation surgeries to the borderline and the benign patients. So this subclassification was important. It is a very good system. It is one of the first systems to incorporate an oncology center in one of the parameters. Why it was important, I'll come to it. It has been extensively validated across a lot of centers, and it is a basis of the further URADS classification. That is the talk of the town these days. So this is just the Adnex model, how this is calculated. Now, it was important to calculate the oncology center in the classification, because there were multiple reports which are coming from all around the world that if the patients are treated in an oncology center, they have improved survival as compared to those who are treated in a tertiary hospital. So it was important because specialization, as we are going to proceed, we are going to specialize in a particular field, and that is going to impact the outcomes. So IOTA Adnex model it is being followed, and it has been again validated. If we compare RMI, LR2 model, simple rules risk model, Adnex with CA125, the Adnex with CA125 is the best model with the maximum diagnostic accuracy, and it is almost approaching the sensitivity specificity of an expert sonographer. So that was IOTA Adnex. So that was the IOTA Adnex model. Now, in between the IOTA Adnex validation and the simple rules, there was also a GI RAT system that was proposed. Now, this was based purely on pattern recognition and color Doppler. It did not have any risk algorithm incorporated in it. So the detection rate overall was low. It was almost similar to the BIRADS in breast, and it was going to characterize a lot of adnexal masses as suspicious, because the probability, as you can see, the GEI RADS 5 is only 20%. So any mass with a more than 20% possibility will be 5, and it will be recommended to act upon these masses. So the acceptance was not that much for this GI RADS system. After all these systems, there was a consensus report that was published, which gave some recommendations, because all these are just systems which are characterizing the masses. What actually we have to do with those masses? Those are the recommendations which were in these consensus guidelines. They told us clearly that pelvic sonography, particularly the transvaginal, that is the imaging of choice along with Doppler imaging. Initial mass characterization either should be performed with the IOTA simple rules or a risk model like the IOTA Adnex model. If a patient, if the ovarian lesion is characterized as benign, the patient can be kept on follow-up, conservative management. And if we are keeping a patient on conservative management, she is going to have serial sonography. So if the rate of surgical interventions are going to reduce, the rate of sonography, the serial surveillance is going to increase. And whenever you have an indeterminate adnexal mass that you cannot classify, you have to go on a second step evaluation. Either you have to go to an expert sonographer, or you can incorporate other imaging modalities like MRI, or you refer to a gynaecologist center for further evaluation. So these are very standard things which we all know. It's just because it's a part of the review of literature. So what was the what was a need? Why there was a need to introduce another system? So the simple rules were not able to classify 20% of the masses. The IOTA index model sub-classified, but the Americans, they were more in favor of pattern recognition. The Europeans were more in favor of the risk prediction model. So the overall acceptance was a little low for the IOTA index model. GI rates did not have any objective criteria, and the acceptance was very low. And the Kentucky, again, it was not validated outside a single center. So all the existing systems, they were not able to bridge the gap between classification and the management of these adnexal masses. So there was a need to develop a universally recognized tool, and there is where the URATs come. Now the Americans, they have therefore published their URAT system, ovarian reporting and analysis, which bridges the risk stratification and the management of these adnexal regions. It's a combination of the American pattern recognition and the European risk prediction models. Now it is supposed to increase the consistency between different interpretations. It will decrease the ambiguity, it will have a higher accuracy, and it is going to provide a management recommendation. It's a collaboration of, again, I would like to repeat, a pattern-based approach and an algorithmic approach. The pattern-based approach, the simple rules, the B rules, M rules, and the algorithm, the IOTA index models. And there is definition of all the risk categories, and their particular management schemes are designed. So these are the risk category already discussed by Dr. Deeksha. So what exactly I want to emphasize is that URATs 1 and 2 are clearly benign things. So they directly, we don't need to reclassify them on the basis of risk, because they don't need any active intervention unless the patient is symptomatic. So 1 and 2 can be clearly managed conservatively, or can be managed in a gynecology center. The URATs 3, 4, and 5, they require further application of the Adnex risk model. And when on the basis of the Adnex risk model, if the percentage is 1 to 10%, then it is 3. If it's 10 to 50%, it's 4. And if it's more than 50% probability of being malignant, then it is 5. So first we apply the URATs 1 and 2, we remove the benign lesions, and then we apply the Adnex model. And that is how the URATs comes into place. And this is just the revision of the URATs 1, 2, 3, 4, 5, and all the things that can be particularly included. So it is an effective risk management, risk-based management system. It has a broader application. There is still, we don't have validation for this system actually, URATs, and still IOTA Adnex is the standard because they're extensively validated here. Still refinements are required. We might need to subcategorize the URATs 4 category, because there might be some difference in the prognosis of the lesions which are categorized in URATs 4. So it's still awaiting refinements, but it's an exciting tool. It's going to bridge the gap between the risk-based classification and the management. So this is the IOTA 5 study. Now all the systems, the classification systems that I've discussed till now, they have included patients only who have underwent surgery. It has not included the patients who have underwent conservative management. So the IOTA 5 study, it's still ongoing. It was started in 2012, but it aims to follow up the short-term and long-term outcomes of benign looking adnexal masses, or both who were managed conservatively and who underwent surgical management. So this will further validate whether URATs is successful in categorizing patients as benign, and whether there is relation with the survival of those patients if we are not missing any ovarian cancer cases. So that is going to validate the URATs. And this is just, again, we all know that if the risk of malignancy is high, it's important that we refer them to specialized oncology centers. And then in oncology centers, the management, it's beyond the scope of this, but in borderline, we can offer fertility sparing management, and in advance, we have to individualize according to the stage of presentation. And secondary metastasis, we have to do appropriate specialist referrals. Now, the IOTA Adnex model, even the Adnex MR model was developed on the basis of the Adnex model in the ultrasound. Adnex MR was also developed on the basis of this ultrasound model. So the primary driver of risk stratification in an MRI, what the most important thing in an MRI is an enhancing solid tissue. So if an enhancing solid tissue is seen in any adnexal mass, ovarian mass, it is significant and it is high probability of being malignant. So that you have to remember, it has a very good negative predictive value, 98%. That means only 2% of the malignancy patient might be missed by MRI. And so just like the Adnex IOTA based on the ultrasound, Adnex MR was developed, and on the basis of Adnex MR, the URADS MRI risk stratification is developed. But URADS MRI, URADS ultrasound, they are still awaiting validation. But they are exciting tools to exclude malignancy with higher precision, higher soft tissue resolution. They can differentiate between the types of fluid: hemorrhagic, old, new, mucin. They can reclassify the non-ovarian tumors, and MRI, of course, has the advantage of completely mapping that particular adnexal mass as compared to the ultrasound, which can only map a particular part at a particular time. And of course, we all know that whenever we think of fertility preservation, MRI is the preoperative standard. We all do. We are in tertiary center, we are not proceeding with mostly with the interventions based only on ultrasound. We are recommending at least MRI in cases where we are requiring fertility preservation, particularly in premenopausal women. And MR, in fact, URADS MRI has a very high potential to subclassify the ovarian tumors. It can in fact tell you the epithelial tumors, whether it is a dysgerminoma, whether it is a granulosa cell tumors, because there is a lot of data that is extracted, and that is it is put into the softwares, and multiple algorithms have been developed, but all this is awaited. The other, we know that ultrasound is the choice of modality for all adnexal masses for characterization and appropriate referral pathways, but there is a role of MRI for characterization of masses, particularly for cancer. There are two things which are in MRI which are important, and first is the addition of the diffusion weight techniques. So the diffusion weight techniques, what they do is that they measure the molecular motion of the cells within a particular tumor. So if it's based, and then they define the apparent diffusion coefficient. So whenever you have a solid tumor, the motion is going to be restricted, so which is called as a restricted diffusion, and they are going to have lower coefficient. So a solid tumor, a high-grade tumor is going to have a lower coefficient, and a benign tumor is going to have a high coefficient. It has going to have a lot of mobility of the molecules. So these diffusion weight techniques actually can detect, malignancies which might not be apparent on the morphology of that mass. Also, in fact, they can predict resectability in case of advanced tumors. These are outside the scope, but they do predict all these resectability. The other thing is, of course, as I told, that any enhancing solid component is important. So the addition of the dynamic contrast enhancement to this diffusion weight imaging again adds more value, because as the contrast passes through the mass, it defines the components of that particular mass, the solid components, the fluid components, everything. And it ultimately, it will help in the URADS MRI classification system. There is volume quantification of the adnexal masses. So MRI is important. If you cannot classify the masses according to the ultrasound-based systems, MRI is the second line investigation, and why it is important that we have discussed. Also, it can help, MRI in tumor response. When we give chemotherapy, it also helps us in tumor response, these diffusion weight techniques. But again, there is a paucity of data. It's still ongoing. We need more data. Now, what role of CT, PET CT already discussed. They don't characterize the masses, but they're important in staging, particularly PET CT for extra-abdominal disease. And they can help in determining preoperative resectability, but never alone. So after all these tools, now it's an exciting time in oncology, because we have now immunotherapy and targeted therapies which are doing wonders to advanced ovarian cancer patients, which were earlier deemed palliative. Just like genomics now has a role, in these targeted therapies and immunotherapies, radiomics is now the future. It's supposed to be the future, because they say that images are not just pictures, they are data. So there are bioinformatic tools which are extracting data from the images which have been stored for years, and then they are combining it with other patient data, and they are going to develop models which are going to improve the diagnosis, the prognosis, and the predictive accuracy of a single ultrasound on an MRI scan in the future. They're going to, they are stipulated to define the tumor heterogeneity and which will correlate with the biological behavior. And it's just an extension of the precision-based medicine, whose wonders we have seen in the form of PARP inhibitors for the treatment of ovarian cancer with survival well beyond 5 years. And now regarding the guidelines, I'm sure all of you are following the standard RCOG guidelines for premenopausal and the postmenopausal women. So we know that any mass which is less than 5 centimeter can be observed. And 5 to 7 centimeter mass, we need to do some additional investigation, and that is MRI, because in premenopausal women, that is for the characterization of that mass. Now in postmenopausal women, we know that CA-125 and it's a good modality for postmenopausal women because we don't have the inflammatory conditions which are there in premenopausal women. In postmenopausal women, important is that RMI of less than 200, we can still offer laparoscopic management for these women because the suspicion of malignancy is less. But for more than 200, we should be offering standard laparotomy approach. As an oncologist, I would just admit that for any ovarian mass more than 5 centimeter, we always recommend open approach. We have to, of course, take care of the intraperitoneal spill, and all of you are aware of these. I don't need to. And this has already been discussed by Dr. Jyoti. And then these guidelines, all of them, they actually say the same thing, that ultrasound is a standard imaging modality. If expert is not available, you can move on to the risk prediction models. CA-125 is the single best protein biomarker, but it is not useful for screening. It helps to subclassify the malignant tumors, but it doesn't differentiate between benign versus malignant. Now, CEA and CA-99 may be particularly helpful to differentiate the secondary metastatic tumors. So whenever you have a young female with bilateral masses with minimal ascites, beware, it might be a second primary. So you have to do a CEA and CA-99. We know that MRI is a second line tool, which combined with the functional imaging of diffusion weight and dynamic contrast. PET-CT cannot differentiate between benign and malignant, but it can detect secondary malignancies and it can stage the disease in terms of extra-abdominal metastasis. Imaging alone, of course, should not be used for surgical decision-making because the sensitivity of any imaging modality that available today is just 70 to 80%. Clinical judgment and tumor markers also should guide the management in a particular patient. These are the SGO guidelines, which important again emphasize that detailed history is very important, as Dr. Jyoti has already, she has given a detailed history and examination that has to be done. There is no replacement for detailed history, clinical examination. And very important these days is the family history of these patients, because now we have, in fact, studies in India have shown that there are 25 to 30% prevalence of all these genetic mutations, which extend beyond the BRCA1 and BRCA2, where they include the Fanconi anemia gene panel. So very important, family, never miss family history in any adnexal mass patient. And of course, ultrasound, as we discussed, pattern recognition, risk-based models. Less than 40 years, always do all 6 markers: CA-125, CEA, CA-99, AFP, beta, HCG, and LDH. Because the secondary malignancies like GI are all more common in young women, and the germ cell tumors are also very common in the younger women. So younger women with something like bilateral ovarian masses, all markers should be done. More than 40 years, generally as a rule, we do only these 3 markers: CA-125, CEA, CA-99. So that's the general that we used to follow in TMH. And for the postgraduates, it's very important, you just remember these, that solid component with a strong color or central flow, more than 4 papillary projections, thick multiple irregular septations, ascites with peritoneal disease, and bilateral masses. These are sinister features. They recommend referral. They recommend a consultation with your senior. And again, they emphasize that bilateral masses also always look with a fine lens when you have bilateral masses in a young female. Take-home message is the same: comprehensive history. There is no replacement. Physical examination, evidence, risk-based approach. You can use either approach, but you have to remember what is the clinical basis of that approach. Choice of imaging, of course, ultrasound, tumor markers already discussed. Always remember, as patient is symptomatic, you have to address the mass. It's not that if it's simple cyst 10 centimeter, patient is having pain, we will not act. We will act. 5 centimeter mass, if the patient has pain, you have to act. You have to address it. You can't just observe it. And suspicious adnexal masses, you have to refer. You should try to refer to specialized centers. where there is availability of frozen section, and if there are considerations of fertility preservation, they can be addressed. The oncologist perspective is that for early ovarian cancer, comprehensive surgical staging is very important, because the patient has only one chance for having the optimal surgery that is going to affect her survival in the long run. So therefore, that is why we are talking about, why we are categorizing all these masses, is because we want not to miss the ovarian cancer, the early ovarian cancer. And it's just not any ultrasound, it's just not the tumor markers. It is a combination of history, physical examination, tumor markers, which was already discussed by Dr. Jyoti. And we are clinicians, we are not ultrasonographers. So always you treat the patient, you see the whole picture, and then you take the decision. And of course, in oncology, multidisciplinary team management is very important. Never be shy to take help from your colleagues of your same department or different departments. And also, it is always a shared decision making. Try to keep the patient in the center of all the decisions that you're going to take for them. So with this, thank you. I would like to thank you everyone for giving me this opportunity. And thank you, Dr. Mala, for reminding me yesterday. It was so sweet of you. And we are well beyond the time, but I hope it was a fruitful session.
Thank you, Vaishali. I think it was a brilliant session. And I think it was, you well mentioned that, how the approach to, imaging in adnexal masses is, either you do the morphological based or you do the risk based, and how each has evolved in history to where we are present. And still we are not perfect. Sometimes we, in all our practice, we find we may be guessing it as benign, it may turn out to be malignant. So systems are not perfect. So you always have to, maintain some precaution wherever you are interpreting these models. And I think you, very well, summed up all the, recent guidelines from the Europeans and the Americans and how they have preferences for different systems. And I think, yeah, ORATS is somewhere, there. And the future also, the radiomics, which you mentioned, and, it will take time. But I think with artificial intelligence and all this coming in, I think, imaging in oncology will be a different chapter in the coming years. I think it was a brilliant talk. And I think anybody else, if he has to comment on the talk. Or otherwise, I think Anuba can take questions. I think the next session is
Dr. Chandra, your comments?
Dr. Mala, it was really a wonderful this thing lecture, and even I could understand, though I don't know anything about the more of the oncology, but I could understand, and I could understand the recent guidelines. That is a very, very important, because there is a mass and you decide, but when you know the recent guidelines, then you can act accordingly, you can counsel the patient accordingly. So recent guidelines has a role there in the management of the patients, and she clearly clearly explain that there is a role of the history, there is a role of the examination, and then there is a role of the imaging. So, Dr. Vaishali, congratulations. You have described each and everything very clearly. Thank you.
Thank you, ma'am.
And you have also given insight about the future. What the future prevails for everyone. So it's my privilege and pleasure to propose the vote of thanks for today evening. First of all, I thank Dr. Kamal Gujral, madam, who has always encouraged us in all our academic activity, and she has been kind enough to give her pearls of wisdom to our evening, to this evening. I thank all the esteemed speakers, Dr. Jyoti, Meena, Dr. Deeksha Rastogi, and Dr. Vaishali Paliwal, who had really worked very hard and given good insight into the approach of adnexal masses. How do we evaluate? How do we do the reading of the imaging system? And what is the society guidelines? I thank all the chairpersons, Dr. Meena Samant, Dr. Harsha Kullar, madam, Dr. Gangadhar Sahu, Dr. Chandra Mansukhani, and Dr. Rahul, who had given their valuable time and given insights into the subject. And I thank all the delegates who have logged in today evening, without whom any program is not useful unless we have good delegates and good audience. And I thank our MOC, Dr. Anuva, who really conducted the sessions very well. And thanks, Mr. Vinod, for giving the background support. Thanks each and everyone for today's webinar. Good night and goodbye.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.
Thank you. Bye-bye.
Thank you,
Thank you.
everyone.
Thank
Good
you.
night.
Good night.
Thank you, everyone. Namaste.